Уважаемые участники конференции, спасибо, что вернулись после обеда. У нас была очень насыщенная программа в течение этих 2 дней. Остались сильнейшие из сильнейших. Позвольте мне начать работу нашей последней заключающей сессии. Сегодня мы обсудим вопросы риск-коммуникации, которые обсуждались, проговаривались неоднократно и сегодня, и вчера. Но наша сессия будет посвящена вопросам мировой практики риск-коммуникации. В рамках сессии запланировано выступление 3 международных спикеров. Все спикеры будут презентовать онлайн на английском языке, поэтому, пожалуйста, подключитесь к синхронному переводу. Я вижу, что первый наш спикер с Южной Кореи уже на связи. Позвольте мне его представить. Mr. Kim, Andrew Kim, Aisha is speaking. Are you with us?
Yes, I'm with you.
Mr. Kim?
Yes, do you hear me?
Пока он подключается, позвольте мне ознакомить вас. Mr. Kim, I'm sorry, we have some technical issues. While we will handle it, let me just introduce you to the audience. It will take a few minutes.
Yes, good, thank you.
Хорошо. Доктор Ким является ассистент-директором Корейского агентства по контролю профилактики заболеваний. Он выступит с докладом «Стратегия информирования о рисках» или риск-коммуникации, как мы называем, во время COVID-19 в Южной Корее. В настоящее время мистер Ким работает пресс-секретарем Корейского агентства по контролю профилактики заболеваний, а во время ковида он был сотрудником команды по управлению вакцинацией против ковид. Доктор Ким, we are presenting your presentation in Russian, so please indicate when we should switch the slide. The floor is yours.
Yes, thank you for having me. I'm an assistant director from KDCA, Korea Disease Control and Prevention Agency. I know I'm given 20 minutes for my presentation, so I will start. Can we move to the slide number 3? Next slide, please.
Just a minute.
Yes, this is the definition and objective we quote from WHO. As you know, the risk communication is the real-time exchange of information, advice, and opinions between experts and community leaders or officials and the people who are at risk. An effective risk communication aims to allow people at risk to understand and adopt protective behaviors and allow authorities and experts to listen to people's concerns and needs so that the advice they provide is relevant and trusted, acceptable, and followed. Next slide, please. This is the principle of the risk communication we quote from US CDC. To make this possible, taking advantage of the 6th principle of risk communication is helpful. You can check those 6 principles in the presentation file. And when we risk communicate with people with the with these 6 principles, then people give their trust for the health authorities and cooperate with the government policy. People's trust and cooperations are very important in minimizing social chaos and damage, and therefore minimizing the death and ending the pandemic at the earliest possible time. Next slide, please. When an infectious disease breaks out, if the government sends relevant information to the people at a late time, people fall into chaos, which lead to more infection and death. This is because people do not know what to do to protect themselves from the virus and infection. Let's take a look at the graph. As you can see in the left graph, if we communicate late with people, then the time to prepare to stop the infection spread becomes shorter. On the right side, if we communicate with people about what to do for protection immediately after an infection disease outbreak, then the infection spread is delayed. This buys us more time to prepare and respond to the emergency. Therefore, this communication at a right time can save more lives and protect the nation from the impact of the pandemic. Next, please. When an infectious disease breaks out, if this communication is not carried out properly and immediately, people's fear of infection and death grows bigger, and the actual level of risk becomes out of control. Therefore, we cannot stress too much the importance of this communication at the initial stage of infectious disease breakout. Next, please. What is risk communication? Risk communication is to help people become aware of risk and the actual level of such risk so that people will accurately perceive the actual situation. And risk communication is to provide right prevention guidelines in detail. Next, please. Let me explain about how we communicate with the news media and public and experts. Next, please. The KDCA continued updating people on the current development of COVID-19 infections and ongoing situation by publishing press release every day and holding regular press briefings and background briefings. Next, please. Also, we held two-way open special briefings where citizens and experts and government officials communicate with each other. Next, please. To ensure that people would have correct information and to ease their anxiety, we spread videos of the open social briefing summaries via online. And what you can see on the file on the presentations are some of the examples that we shared with the people. Next, please. And we also sent messages of consolation and empathy to persuade people to work together to help overcome the pandemic. Some of the examples you can see on the screen. First example is it is the remark from the head of the KDCA. It says, please comply strictly with social distancing rules to help create an environment where our children can enjoy bright and joyful days with their friends at school again, as they did before the pandemic. These are some of the remarks that our head made during the pandemic for consolations of the people. Next, please. And to prevent the spread of the virus, one of the measures that we have to do is to find out the contact in suspected patients and confirmed patients and to treat them. But when they hide themselves and do not report their health condition to the health authority, then it becomes very difficult to stop the spread of the virus. And when the personal information of contact, suspected patient, and confirmed patient is disclosed, they tend to hide themselves from the society, and such disclosure of their personal information can cause secondary damage on them. So to stop the spread of the infection at an earlier stage of the pandemic and to find out and treat contact, suspected patients and confirmed patients at the earliest possible time, we established the standard for disclosure of the information on confirmed cases with which the least amount of the personal information necessary for the infection prevention can be disclosed to the public. Next, please. When an infectious disease breaks out, people's fear of infection and death grows bigger than the actual level of risk and becomes out of control. This fear causes larger damage to society as a whole than the actual level of the risk do. Next, please. The general public tend to have such great fear because they perceive risk in a different way from the expert. The general public unconsciously perceive risk according to their emotions and instinct, whereas experts perceive risk according to data such as fatality rate and probability. So effective risk communication with the public need to start from understanding the public. Next, please. So we immediately shared information on confirmed cases of unknown virus when they were reported in December 2019, when we immediately informed the people of confirmed cases having been reported in South Korea, as well as of the alert level. We also informed people of the COVID-19 response guidelines that have been improved to reflect ongoing situation. Next, please. We shared evidence-based prevention rules with the public. These are some of the examples, the materials that we shared with the public during COVID-19 situation. Next, please. These are also the examples that we shared with the public. Next, please. In communication with the public, infodemic is a matter that should be dealt with immediately because infodemic causes greater social and economic damage. So we are not just fighting an epidemic itself, but we're also finding the false information too. Next, please. Let me share some examples of the infodemic. More than 700 people have died and more than 90 people lost their eyesight in Iran after drinking toxic methanol. A mobile phone component became an issue in the UK because of ridiculous rumor that 5G wires spread coronavirus. Next, please. In South Korea, a church sprayed salt water inside the mouth of the people based on a false belief it would help prevent the spread of the coronavirus. But by using the same spray bottle without sterilizing the nozzle, it resulted in 46 churchgoers infected. Next, please. In response to infodemic, 6 government ministries worked together. One of them was us, the Ministry of Health and the Disease Control Agency. And against infodemic, we continued monitoring false news on vaccines and carried out fact-checking and took legal actions. And the KDCA, our government, our agency, spread scientific facts through the news media, press briefings, press release, the website, and card visuals. Next, please. These are some of the fact-check sheet and the card visual that we shared, we provided to the public. Next, please. And we gave message for consolations and empathy to minimize psychological isolation caused by social distancing and to enhance the public's interest and participation in COVID-19 control measures. For example, we should keep ourselves emotionally connected, though we are physically apart from each other. Next, please. And we also provided contact information for counseling and relevant guidelines through the KDS's social network channels too. Next, please. To help overcome the pandemic earlier, the whole nation's unity was very important. All the people in the nation should work together as a one team. And the COVID-19 pandemic continued more than 2 years. So we launched a campaign to strengthen social solidarity. For example, All Thanks to You campaign and Cheer Up Korea campaign. Next, please. We also listened to the KDCA communication group of citizens composed of all age group to collect various views from citizens regarding social distancing laws and government's policies. Listening to people's voice was very important to deliver health policies and prevention laws in a way to be well understood and accepted by the citizens. Next, please. We are running the expert advisory group too, and we are trying to hear many ideas or opinions from various fields of medicine, mass media, public relations, and psychology. We held regular meetings with them. This way, we would develop this risk communication strategy and messages that are adequate for the public. Next, please. To increase people's access to scientific health information on COVID-19, we invited medical professors to share their scientific views with public online in the form of card visual, newspaper column, and interviews. Next, please. These are some of the interviews that we did through the media. Next, please. For communication with people, we also cooperated with the private sector too. We collaborated with universities and survey companies to carry out regular surveys once or twice every month about the public's perceptions of the pandemic, the level of their compliance with COVID-19 prevention rules, and the level of their trust for the government. And we developed message and communication strategy based on these results. Next, please. We developed a chatbot through a partnership with an IT company, and the chatbot served as a communication tool. We also collaborated with dairy company to put a notice on milk bottle for children. This gave children easy access to basic prevention guidelines such as mask wearing and social distancing. We also created animations on COVID-19 prevention laws for children. Next, please. Making the prevention guideline into the content of our entertainment program was effective in attracting people's attention. Celebrities appeared on various entertainment, introduced prevention rules, and exchanged opinions on how to protect the body from the virus. We also invited influencers to share good examples on basic prevention rules through SNS channel. Next, please. Now, it is going to be a summary of what I have told you. Next, please. Let me summarize the risk communication strategy of the KDCA. During the initial stage of the pandemic, our risk communication was focused on building trust with the people. To make this possible, we integrated various communication channels into a single one, and this way we maintained a unified voice. We provided correct information immediately and transparently, and we responded to false or misleading information immediately and prevented the spread of the false information. Next, please. Next, our risk communication was focused on building social solidarity and people's cooperation with the government. To this end, we emphasized out of warm heart with the public who are cautious in a crisis, and we involved all the citizens in a two-way communication to ensure that they can see themselves as part of the COVID-19 response team. Next, please. Lastly, we communicate with people to fill in the blind spot of the accessing information. To this end, to this purpose, we had careful consideration for those who are lacking accessibility to information. This was extended to the community's trust for the government. Communication tailored to the need of the children, the elderly, and those with disabilities not only filled in the blind spot of the access to information, but also enhanced social solidarity and people's will to overcome the crisis. And we communicate in an easy to understand Korean language and easy to read expressions. This is because if foreign language difficult to understand, the foreign language which is difficult to understand, if the foreign language is used constantly in the Korean text during the crisis, it prevents the public from having an accurate awareness of the situation and may exclude the elderly from having proper access or proper understanding about the coronavirus. This is the end of my presentation, and I hope you liked it. Yeah, that's it.
Thank you so much. Thank you, Mr. Kim, for such informative presentation. We have a minute. Let me check with the audience if they have any question. Уважаемые участники, если у вас есть вопросы, вы можете задать. Позвольте мне воспользоваться случаем и задать первый вопрос. Не могу его не задать. Всем известно, что до ковида Южная Корея сталкивалась со вспышкой эпидемии CARS, то есть птичьим гриппом. Мой вопрос звучит так. Были ли изменения в стратегии риск-коммуникации во время эпидемии птичьего гриппа? И можем ли мы предполагать, что этот опыт способствовал тому, что вы оказались более подготовлены к ковиду? Если бы вы немного прокомментировали этот момент. Mr. Kim, did you hear my question in English?
Yes. What is the question?
Okay, the question is regarding CARS.
Oh.
We wanted to know if there were any changes in risk communications after CARS in South Korea, and can you assume that that experience was very helpful for you to be prepared for COVID in 2019?
Yes. There was some of the virus that took place before the COVID-19, but at the time there was not a proper organization, or we did not have much experience about how to handle those viruses, because KDCA, Korea Disease Control and Prevention Agency, was established during the COVID-19 situation. So actually, our agency was under the Ministry of Health before the COVID-19. So before the COVID-19, we did not have much information, or we did not have proper organization to deal with those virus issues. So I think in the past, we did not have enough resource to deal with, to handle the virus situation. But after COVID-19, I think we have improved a lot. So to answer your question, we were not that good at dealing with the virus situations before COVID-19.
Thank you so much. Thank you for your meaningful contribution to our conference. If you do not mind, we will move forward. Thank you.
Yes, thank you.
Следующее слово предоставляется доктору Ребекке Кинг, ассоциированному профессору Университета Лидс, руководителю Нафилдского центра международного здравоохранения и развития в Соединенном Королевстве Великобритании и Северной Ирландии. Доктор Кинг обладает большим опытом проведения прикладных медицинских исследований. Она обеспечила экспертное руководство примерно в 30 научных проектах в таких странах, как Пакистан, Непал, Бангладеш, Китай, Гана, Замбия, Уганда, Мозамбик. Тема доклада доктора Кинг – вовлечение общественности, устойчивость к противомикробным препаратам. Она будет рассказывать о кейсе в Бангладеше и Непале. Доктор Кинг, are you with us?
Yes, I am. Can you hear me?
Yes, thank you so much for joining us. The floor is yours.
Thank you very much. Good afternoon, everybody. Good morning from here in the UK. Thank you very much for inviting me to participate in this conference. I really appreciate the opportunity to be here. Thank you. I think my introduction has just been given. My name is Rebecca King. I am a social anthropologist by training, and I have been working in global health for the past 15 years or so. I'm head of the Nuffield Centre for International Health and Development at the University of Leeds, and I am the co-chair of AMR at Leeds and the co-chair of CE for AMR, which is the position that I'm speaking from today. CE4AMR is a global network that aims to address antimicrobial resistance through community engagement methods. Slide 2, please. Next slide, please. Thank you. Today, I'm going to share some thoughts on community engagement, and I'm going to share an example from a study that I'm currently leading in Bangladesh and Nepal, which uses community engagement to address the social and behavioural drivers of antimicrobial resistance in rural settings. It's worth discussing at the outset what we mean when we speak about community engagement, and to clarify what we mean by community. So in my work so far, community has generally been defined in very straightforward terms, more or less corresponding to the idea of the general public or the lay person. And this has been really useful in the work that I'm doing, because the World Health Organization provides a set of clear expectations about what the lay person can do in relation to addressing the drivers of antimicrobial resistance. So, for example, to acquire a prescription from a qualified health professional, or to complete the course that you have been prescribed. However, my team and I are very well aware that there are communities within communities, and that communities are rarely homogeneous. So we could be speaking about a community of healthcare providers or a community of farmers. And some of the important reasons for us to define community are to be able to really think about inclusion in what we do, to avoid excluding people, and to be able to produce interventions and policies that are appropriate to the capacity of those people to act. Next slide, please. It's also worth clarifying what we mean by engagement, and I just use this slide to point out that there are a number of terms that are quite often used interchangeably or alongside each other, and those that are highlighted in bold are probably the most frequently used these days, and there seems to be a move towards the term engagement rather than some of the other terms, but they are used quite interchangeably. Next slide, please. I'm sure that most of us are aware that there are various frameworks that help us to think about community engagement, and they tend to demonstrate the distinction between a type of engagement that is hierarchical, so the sharing of information with the expectation of compliance, and a different form of engagement that tries to break down hierarchies and produces more equitable and collaborative interactions. So these would be approaches where stakeholders come together to co-produce solutions to problems that have been mutually identified. So on the slide, you can see one example of the framework. This is known as the ladder of participation. It's a really old framework. It's about 50 years old this year, and I still do find it a very useful one. It shows us that at the bottom of the ladder, there's a type of participation where information is provided to the community, and there is this expectation that they will comply. And in the middle of the ladder is a form of participation where an organization or a department or a research group, etc., shares a plan that is open to change through discussion and collaboration. And finally, at the top of the ladder, there's a type of engagement where the problems and the solutions are identified by the community, and the role of the organization or the department or the research group is to support that community to accomplish its goals. Next slide, please. When I'm teaching my students, I like to give the example of recycling schemes in the UK as one of the more hierarchical forms of engagement. So several years ago, local councils provided information about what residents are expected to do in terms of recycling their waste. And we were given the appropriate equipment to do this with. So we had different bags and boxes, and we're expected to comply with that. So that's one form of engagement. There's a very nice study from Nepal, which I have referenced here. I wasn't involved in it, but I really, really like it, and I recommend you take a look at it. It illustrates community engagement from much higher up the ladder. So in this example, women's discussion groups were formed to identify problems that are faced within rural settings around safe delivery and care of newborns. So women were facilitated to develop low-cost solutions, such as preparing delivery kits, planning for birth, creating savings pots for emergencies. And birth outcomes improved a lot through a low-cost, sustainable, potentially, and scalable engagement approach. I'd like to say that we can't say that one way is always the best way. Some situations may require different types of interventions, and a degree of facilitation is almost always required. But other situations might be more amenable to different types of engagement. Next slide, please. As you can see here, WHO has been using a definition of community engagement that emphasizes the relationships that occur within the process of engagement. I really like this concept and the importance that is given to improving the quality of the relationship between stakeholders in order to impact on health outcomes. And in my work with others in CE for AMR, we have defined community engagement as a participatory process through which equitable partnerships are developed with community stakeholders who are enabled to identify, develop, and implement community-led sustainable solutions using existing or available resources to issues that are of concern to them and to the wider global community. So within this definition, we try to emphasize the ideas of partnership, equitable partnership, participation, and solutions that are led by communities. Next slide, please. The study that I currently lead is called COSTAR. It stands for Community-Led Solutions to Antimicrobial Resistance. And our vision is to co-create, implement, and evaluate an innovative intervention that addresses the drivers of AMR. Next slide, please. We are currently implementing COSTAR in 2 settings. That's Kamilla district in Bangladesh and Kapilavastu municipality in Nepal. We are nearing the end of the study, but we haven't completed it yet. Next slide, please. You can see the objectives here on this slide. They are essentially to develop a contextualized intervention for community engagement, to implement and evaluate that intervention by assessing its effectiveness for improving knowledge, attitudes, and reported behaviors, looking at its cost effectiveness and the cost of scale up, the extent to which it is equitable, gender sensitive, and participatory, its potential for implementation on a national scale in Bangladesh, and in Nepal, we're looking at replication to a new context. Another objective is to implement a robust capacity strengthening strategy. And the last objective is to look at research uptake to increase the visibility of community engagement approaches within the wider AMR research landscape. Next slide, please. Just to put us all on the same page, I will just mention that AMR occurs when bacteria, viruses, fungi, and parasites change over time, and they no longer respond to medicines, making infections harder to treat and increasing the risk of disease spread, severe illness, and death. And as a result of drug resistance, antibiotics and other antimicrobial medicines can become ineffective, and infections become more difficult or even impossible to treat. Next slide, please. So AMR is currently considered to be one of the greatest threats to global health, food security, and development. And I think it's really important to emphasize that, although I'm very sure that the people in this conference are fully aware of that challenge. WHO has declared AMR to be one of the top 10 global public health threats facing humanity. And in 2019, Dame Sally Davis, who was the Chief Medical Officer in the UK, declared antibiotic resistance to be a threat that is as significant as climate change. So it's kind of high up on the global agenda, a really important issue. The impact of AMR on human health is considerable. Again, I'm sure we're all very well aware of that. Analysis showed that there were 1.27 million deaths directly attributable to bacterial AMR globally. That was in 2019. A 2014 report warned that drug-resistant diseases could cause 10 million deaths per year by 2050 if we don't take action. We're probably all aware that there is a limited pipeline of new antimicrobials, and the economic costs of AMR to individuals and to health systems are known to be really substantial. Healthcare expenditure is driven by longer hospital stays, higher risks of complications, less effective treatment options, etc. And the estimates of the longer-term costs of AMR are put at $1 trillion annually from 2030 if no interventions are implemented. So it's going to be expensive as well as very serious in terms of public health. It's also really important that I say here that AMR is what we call a One Health challenge, and my work looks at AMR from a One Health perspective. One Health is an approach that recognises that multiple sectors need to coordinate in order to achieve better outcomes. In particular, One Health recognises that human, animal, and environmental health are interconnected, and we can't solve complex challenges without collaboration across sectors. So it's really important that we work collaboratively in these different spaces, because many of the same microbes infect animals and humans because they share the same ecosystems. So one sector alone may not be able to prevent or to diminish the challenge of AMR. Next slide, please. So this is quite a dense slide, so sorry about that. You might be able to look at it later. But in COSTAR, we are using an approach called the community dialogue approach. This was developed by one of our partners, Malaria Consortium, and we've been working with it now on AMR related issues for around 5 years. So just to give a little bit of background, the community dialogue approach was adapted from something called the integrated model of communication for social change. And this model assumes that a stimulus is required to trigger dialogue amongst community members about issues that concern them. Dialogue is understood as a process that results in collective decision-making to resolve these issues. In the community dialogue approach, the stimulus is both external, so the provision of training and tools, something coming from outside the community, and internal to the community, selection of volunteers mobilize participants, etc. So volunteers are given the flexibility to tailor the community dialogues to the needs and requirements of the community. The sessions are designed to be very participatory, and each community dialogue concludes with participants committing to a course of action. And they're also strongly encouraged to spread information through word of mouth and to set a positive example amongst family, friends, etc. So you can see our theory of change on this slide. And we have identified factors that we think are important in terms of the potential for sustainability and scale of this approach. We identified these both from a really long literature review, an umbrella review of systematic reviews, and also from our experience, what we've been learning in the field over several years. So these factors, which you may or may not be able to see on the slide, include things like multi-sectoral collaboration, embedding the approach within health, animal, environmental systems, etc. And you can also see on the slide that we identify 3 clear stages of our intervention, each with activities and anticipated outcomes. So we predict, with the theory of change, that the outcomes from the 3rd and final stage will be around changes in knowledge, attitudes, and practice in relation to AMR across the population. Next slide, please. So in Bangladesh, we are assessing this approach through a cluster randomized control trial. We're working in 5 sub-districts of Camilla, and we have 50 clusters. And the clusters are geographical regions that are located around community clinics. So on this slide, you can see some key findings from our baseline survey. So for example, we found that 82% of participants had heard about antibiotics, but only 12% had heard about resistance. Actually, we conducted a survey about 2 years before this baseline, and the number of people who had heard about antibiotics was much lower. So I do wonder whether that has something to do with the pandemic and to do with information and to do with discussions around medications, etc. So we saw a big change like pre and post pandemic. Can I have the next slide, please? We started implementation a year ago, and we expect to complete the implementation in January 2024. We trained 221 facilitators and 50 supervisors, and each facilitator is expected to deliver 11 community dialogues in 2 different venues. So we expect 4,862 CDs, community dialogues, to be delivered in total. Now, of course, that's the target based on the number of facilitators trained and assuming that everything happens absolutely according to plan. So I don't really expect 4,862 CDs to be delivered. I expect the number may be somewhat lower, but that's obviously part of our research to find out what happens. Next slide, please.
Sorry, Dr. King, we can't hear you.
Yeah, next slide, please. Thank
Okay.
you. Thank you. That's right. I think that's right. Yes, thank you. So as of October 2023, so last month, we had conducted 2,969 community dialogues, and the population coverage was around 53,000. It's important that I explain that. So what we mean by that 53,000 is that around 53,000 individuals have attended a community dialogue. Now, we don't know whether the same individuals are repeatedly attending or whether they are all different individuals. We can't get that level of detail. But our expectation is that those 53,000 attendees will also be sharing information more widely within the community. The dropout rate of facilitators has been 13% to date. That might sound like a lot. Actually, I find myself quite reassured by that. The facilitators are unpaid volunteers. So it's pleasing that 87% of them have delivered the intervention to date. We haven't completed our study yet, so I can't tell you the final results. I don't know what they are. And I don't have any hints either, because we don't have any end-line data collection. And even if we did, we wouldn't be looking at it yet. But we do have some really useful process data. So one of the things that we've been doing is collecting what we call decision logs from each community dialogue session. And in these decision logs, we see participants agreeing, for example, to obtain a prescription for antibiotics rather than buy them over the counter, or to complete the course of medication as advised. So we do think that the indications are positive, but we won't know until we complete the study. Next slide, please. So I would like to thank you very much indeed for listening to my presentation. Thank you again for inviting me and for having me in your conference. And I'm very happy to answer any questions that you have.
Thank you so much. Уважаемые участники, если у вас есть вопросы, у нас есть время для Q&A сессии, можете их задавать. Сұрақты қазақ тілінде қойсаңыз болады, аударуға көмектесемін. Oh, thank you for your time, experience, and expertise, Dr. King. We value the knowledge we just got very high. I believe our audience have a lot of questions, but do you mind if we will send it later to your email address?
Sure.
So thank you for being with us, and let us to move forward.
Okay, thank you very much.
Thank you. Со следующим онлайн-докладом на тему информирования о рисках, взаимодействия с общественностью и управления инфодемией выступит Кристиана Салви из Европейского регионального бюро ВОЗ. Кристиана является региональным советником по информированию о рисках взаимодействия с сообществом и управления инфодемией. В течение 20 лет госпожа Салви оказывала консультативную поддержку странам Европы, Азии и Африки. А в последние годы она возглавляет группу реагирования RCCEIM. Об этой инициативе она чуть позже подробнее расскажет сама. Christiana, are you with us?
Yes, I am. Can you hear me?
Yes, we do. Thank you so much for joining us. We know that you have a very busy schedule.
Thank you. Thank you so much for the invitation. Can I share my screen?
Do you have your presentation in Russian language?
No, I have it in English, but I can go through the English version and just ask you to change the slide. That's very fine to me.
Okay, we're sharing your presentation, and please just guide us when we have to switch the slide.
Yeah, but sorry, if you have the Russian version, that's very fine to me. We can use the Russian version here on the Zoom link, and I can just turn my slides myself. Is that okay?
Yes, I suppose, yes.
Great. Okay. So thank you so much for inviting me. This is so exciting being here with you today. Here I'm actually joining from Rome, which is my hometown, and it's 10:15 in the morning. We are a few hours ahead. It's really a pleasure to be here with you and presenting our experience in the context of risk communication, community engagement, and infodemic management, particularly referring to the case of COVID. Can I have the next slide, please? So in this presentation, I want to address why RCCIM, this is the acronym that we use to refer to this area of work, risk communication, community engagement, and infodemic management, is at the core of emergency response. The lesson we learned, particularly during the COVID pandemic, and how we are building back better for the future. Next slide. So again, this is the first part. Why is it at the core of emergency response? Next slide, please. So I'm starting with a quote from the Director General of the World Health Organization, Dr. Tedros, that I trust many of you know. And at the peak of the pandemic in December 2021, he made a call to all member states of the world to strengthen their work on risk communication, community engagement, and managing false narrative, really signaling how central to this area of work is to responding to health emergencies, and particularly to COVID. Next slide, please. So I just want to highlight in this slide, just describe a little bit what we are talking about. So risk communication is basically this pillar in the response that communicate risks and protective measures to target audience, specific audiences, based on their perception and insight. Community engagement engages affected community and community actors to co-design and co-deliver intervention. And the third, which we call infodemic management, uses social listening to understand what false narratives are circulating, but not only false narrative, also overabundance and voids of information. These three areas work as one. So RCCIM enables and empowers individuals and communities to take informed decisions to protect their health from emergencies, and as such contributes to the emergency control. Next slide, please. And I would say it's high time that this area is really acknowledged as central to emergency response. And I make a very clear example here. During emergencies, delivering health intervention and health services alone is not enough. You can imagine delivering the best vaccine option, the best treatment option, but unless people go and access these services, they will be unused. What RCCIM does is actually bridging service delivery, and service access. And I make it very clear. You see in the pink stripe, what matters at the end of the day is not vaccines, but vaccination. What we want to make sure is that people vaccinate themselves. So delivering vaccine is not enough. We need to put in place all the methods and structure and system to make sure that people go and access the vaccine. And with this understanding, RCCIM has been really positioned very highly in public health agenda as a public health intervention, as important as biomedical measures to the successful emergency response. Next slide, please. So I'm showing you in a nutshell the new framework, the new global architecture of WHO and the way we are going to work in emergency in the next future. And this is fully mirrored in Preparedness 2.0, that is going to be the regional strategy where all European countries will be engaged, including Kazakhstan. As you can see from this picture, it's very clear. Where are communities? At the very center. The other revolving systems are the subsystems that contribute to the community protection subsystem, which is in the center. Dear people, dear experts, I've been working in this field for the last 20 years. And this is, I can tell you, this is unprecedented. I've never seen these community protection, communities at the center of emergency preparedness and response. It is happening as we speak, thanks to the experience that we are harnessing in the COVID pandemic, but also other emergencies that are emerging in our region. Next slide, please. Now, let's go to the lesson that we learned across the three technical areas: risk communication, community engagement, and infodemic management. And I would say the hard way, because, I mean, we all know how COVID has impacted all of us. So next slide, please. So this is a paper that we published last year in October, and it's a compendium of case studies in terms of COVID, basically looking at various interventions in this area of work. And by the way, there is also a great example here from Kazakhstan. This publication is available, and I'm happy to share the link. But what I want to basically share here is that we have 10 lessons that we have shared with member states that can be clustered in 3 points. And I'm going through these 3 points in the next slide. Next slide, please. RCCIM as a public health intervention. I mentioned that. We understand now how this is bridging health service delivery and access. It is a public health intervention. It is a technical area, and it needs to be embedded at every phase in the emergency cycle, from prevention up to recovery. The best prepared country, this is what they do with the whole of society and whole of government approach, and allocate adequate and sustainable human and financial resources. Next slide, please. In this slide, I will go a little bit deeper, because this is a bit the principles that contribute to a strong RCCIM intervention. You can see from this image, you have trust in the middle, and trust in the single goal that we want to achieve to increase the opportunity that people, or communities, that individual will accept the guidance from health authorities. These lessons might not be new, but definitely in COVID brought them at the forefront. So the 3 lessons I'm going to look at is about uncertainty, about coordination, and about two-way communication. Next slide, please. I want to look particularly now at the uncertainty element. If you reflect a few seconds about what is the difference between communicating in a context of seasonal influenza and pandemic influenza, what comes at the top of your mind as the critical feature? What is make these two communication different? And you think 2 seconds about this. I will go to the next slide to unlock the learning. Next slide, please. The main difference is that when you speak on seasonal influenza, you speak about what is known. You know the virus that is foreseen, that is projected. You know what intervention we have, but you know the vaccine. you know the measures. So your communication is based on what you know, and you can have a communication campaign based on very solid science. When it comes to situation like pandemic, this is pretty much based on what is not known. You all have experience of COVID and how at the very beginning we had so little information, and then science evolved and we had to really adapt our information and guidance based on the evolving science. Next slide, please. This is really linking to the art of speaking in uncertainty. What does it mean? Like I mentioned, at the beginning, evidence is weak. Our guidance needs to be based on this weak evidence. Evidence evolves and our guidance changes. This is absolutely normal in an emergency when we have an evolution and development of science, and thus guidance needs to be adapted to this evolution. What is not normal is that organizations and governments are criticized for that. What we need to do better is speaking in uncertainty, which means that really making very clear to the public, to the stakeholders, that we are basing our guidance on evidence at that point in time, based on what we know and based on what we don't know, and setting the expectation that this is going to change very likely in the next future. We need to repeat it very often because people, stakeholders, don't want to hear black and white, grays. They want to hear black and white. People don't like the grayness of science. So it's also a matter of educating, but also building the health literacy so that there is an understanding of how science works. Helping people to understand that the situation and recommendation change over time definitely increases the trust. Next slide, please. The second point, and you can follow in the little design that I put at the top of the slide. The next element is coordination. We know how coordination is important at the level of the whole of government. We are talking within the health sector. We are talking across government sectors and across government administration levels. This is extremely important to make sure that our messages are consistent, because consistency reduces confusion. So it's a whole of government, but it's also a whole of society, joining hands with a number of stakeholders and partners, including civil society organizations, community entities, community groups, influencers, the private sector as needed, as well as international organizations. Again, this ensures that messages are consistent, but also maximizes the outreach to different communities and also help everybody to have search capacity based on everybody's resources. Next slide, please. And then the third point, which is so close to my heart, which is risk perception is a reality. So the importance of listening. I'm showing here what we call the Sandman matrix. Peter Sandman, you might know him. He's a prominent scholar in risk communication, and he developed this matrix time ago to explain the power of risk perception. We are still using it, and I'm going to explain this matrix with one example that relates to my personal experience. So on the horizontal line, you have the hazard. On the vertical line, you have the emotional reaction of people to this hazard. The risk communication intervention needs to take account of both, not only the hazard, but also the emotional response. And again, let me make this example. And this example refers to my experience with Ebola in West Africa in 2014 and 15. At that time, I was deployed immediately in the middle of Guinea, where everything started. At that time, the hazard was high. Of course, we are talking Ebola, but the perception of the population of the community was extremely low. They didn't know Ebola. This was the first time in West Africa. They had other problems, other issues. So for them, Ebola was not an issue, was not a problem. So you can see the hazard was high, but the emotional response was very low. So where are we? We are in precaution advocacy. We needed to raise the level of perception to the level of the risk. Then I went back to Europe. I was managing the response from the European region to Ebola at that time and the risk of importation of cases. In Europe, we had a completely opposite situation. where the hazard was low because the risk of spreading of Ebola in Europe was extremely low due to the strength of our health system. On the other side, the emotional response was extremely high. People were in panic in Europe. So you see, we are completely opposite. We are in the square of outrage management, where we needed to reassure people to bring down the risk perception to the level of the risk. In the third moment, I went back to Guinea in 2015 in the capital, Conakry, where we were at the peak of the emergency, hazard was high, emotional response was high. We were in the middle of crisis communication. So you see, this is to show you that the risk communication strategy don't only take into account the hazard, the risk. With the same risk, you have different strategies because they basically put together both the risk and the emotional response. Next slide, please. And everything starts with evidence generation. So to really understand what is the risk perception, but not only the risk perception, the insights, the beliefs, the traditions, everything that is at the top of the mind of your audience, you need to listen to them. There are different ways of doing it. You can do passively through social media and media. You can do active through operational research, surveys, quantitative research, qualitative research, through interviews, focus group discussion, or through behavioral insight studies. Whatever you do, whatever you apply, you need to know that this is a step that is necessary. You cannot have a strong risk communication strategy unless you listen, unless you understand your audiences, and you need to collect this evidence, but also analyze and incorporate it. The other element is communities at the heart. We saw it. We know that communities are the first to tackle emergencies, and they are also the last that stay there to build the system and the structure as we go in the next phase. And partnership with communities can really create a bridge between health authorities and individuals and really make a difference in ensuring the support to the emergency. We have identified through COVID 6 main influencers that can really make a difference in influencing people's decisions. Health workers as the first one, and I'm going to describe a little bit about that, but also young people, religious leaders, community leaders, journalists, and the civil society organization. Working with them in peacetime and establishing the relation to be activated during the response can really make a whole of a difference as we respond to emergency. Next slide, please. Working with communities means mapping the community, establishing a dialogue, receiving and incorporating insights, the listening, leveraging on what is already there, and creating and delivering solutions together. So this is really at the core of everything we do. Next slide, please. There are different levels of community engagement, from information to empowering. Of course, we want to move throughout this arrow to get as much as possible to empowering community to own their own solution through giving also the tools, the system, the training, but also the funding to be able to be really the actor of the solution. Next slide, please. And this is just an example of 8 projects that we established with 11 civil society organizations throughout COVID, really showing that each of these organizations in different countries was really working with different audiences, with the women, with young people with disability, with older people. And they are in such strong position to engage this community because they are close to them, because they have their trust, and because they know them. Next slide, please. I was talking health workers at the center. And this is lesson 9 of the 10 lesson that I just showed. One-to-one communication by health workers to patients is central, and health workers are among the most trusted source of information that can really have an influence on people's behaviors. Next slide, please. There are 3 essential roles that are identified, of course, traditional roles when it comes to health service, self-protection, and this is the traditional role that has been identified, of course, for health workers. Next click, please. But the new role, the new important role that is identified through COVID is health workers as influencers. are those with their behaviors, but also their counseling, their work, their communication to really make a difference. Next slide, please. So interpersonal communication is really, again, a public health intervention within RCCIM. Health workers can encourage protective measures. They can listen to their patients and address their concerns. They can advise in case of suspect or confirmed disease, communicate with the relatives, not only the patients, reducing the stigma with the right language, and act as health mediator when there are refugees or migrants or people with different culture. Fight false information and really be a role model. When health workers uptake vaccine, there is a higher chance that patients will follow their example. Next slide, please. I'm going now to talk about the infodemic. Infodemic has been identified as excess or void of information, as well as false or misleading information. You know that this terminology has been defined by WHO Director General, highlighting really this parallel pandemic with COVID. Next slide, please. There are 5 phases of infodemic management that we have identified. I will go very quickly through them. One is how basically detect the signal through monitoring of different information, and then verify the signal through different techniques, including fact-checking, assessing the risk. I would say this is the most important. We have 3 criteria to identify the opportunity to respond to signals. One is the credibility of the source, one is the spread of the rumor or misinformation, and one is the health damage that we can cause. Based on this, there is a response designed through a number of techniques, and I will go a little bit deeper on a couple of them, and then the outreach strategy. Next slide, please. Talking about debunking and pre-bunking, maybe many of you have heard about this terminology. These are some of the techniques we use to basically address false narrative. Debunking is a reactive method. One example is the truth sandwich, where you have a fact, and then you refer to the false information, and you close with another fact. So basically, the false news is basically taken between 2 facts. And then the pre-bunking, which is actually a proactive mode that exposes manipulation techniques. One of the best ways that we have seen is the gaming, where basically the user is in the shoes of someone who spreads false information and understand the technique, so they are better able to identify them as they are exposed to false information. And then my last part, building back better for the future, I will be very brief here. Next slide, please. So there are a number of priorities that we have for Europe and Central Asia. We are working on, as we speak, health literacy to improve people's ability to understand science and health risk, engaging the civil society and developing influencer series. We have developed on religious leaders, on young people. We are working on the next one on health workers. Social listening, establishing the tools, the structure, and the system at the regional and country level, how to manage in the infodemic and establish partnership and alliances in the European region and the country level. Working on artificial intelligence, this is the new frontier that we need to consider, but trying to do this in a way that is as safe as possible and providing an innovative capacity building offer. Next slide, please. So there has been a lot that has been going on in capacity building. I mean, in the last 10 years, we have been so much to build these capacities on RCCIM across different countries. Next slide, please. But in the next couple of weeks, actually, we are launching a new offer in basically a new digital tools that will support countries to map their capacity, but also to develop their RCC plans, going throughout 10 modules that will both develop their plans, test their plans, and build their capacities. And all of these is embedded in the RCCIM school that we launched last October, and we are continuing in different countries. The second edition of the RCCIM school has been in Kazakhstan with our colleagues and experts from Kazakhstan. And this is, next slide, please. When it comes to building capacities, we're also looking at working with universities to embed RCCIM in university curricula of health, public health, medical students, and communication. We don't want to train health workers where they're already professionals. We want to catch them early when they are medical students and really understand that this is the next frontier of their competency in health emergency. And then my last slide, please. In conclusion, RCCIM leads to trust that drives acceptance and uptake of protective measures and save lives. As such, is a public health intervention, evidence-based, and is the most acknowledged area central to emergency mitigation and control. This is the new frontier of emergency capacity that bridges service delivery and access, and we are working to build the capacity of health workers, of government officials, and of the next cohort of professionals with this essential emergency competency. And this is, next slide, please. So this is the end of my presentation. I want to thank you very much for your attention, and I'm here to answer any question as needed. Thank you.
Thank you so much. Thank you, Christiana, for such informative, detailed information. A lot of things to think on. Дорогие участники, если у вас есть вопрос к Европейскому региональному бюро ВОЗ, у вас есть уникальная возможность их задать сейчас. But before we proceed, may I start with my question? According to RCCIM trainings to be launched in November 2023. You know, Christiana, here in the conference, we have a significant part of participants who are the press service managers, PR managers, working in the regional offices of the Ministry of Health of Kazakhstan. They're working with people, they're communicating with people. Can they apply to RCCIM training program, and what should we do for it? Thank you.
That's such a great question, and thank you for that, because this is really those experts that we do want to engage to really look at communication, not only focusing on media communication, on external communication, but really to change the behavior of people in health emergencies. And definitely these tools will be available in English and Russian. This is very important. So they will be made available to all the countries, of course, including Kazakhstan. They will be made available online, but of course we can engage with all the experts to be trained to use these tools. So it's just a matter of letting us know, and we'll make it work for all of you.
That's perfect. Terrific. Thank you so much. I know that you have more meetings today, so we don't dare to keep you much. Thank you for being with us. In the case you have more questions, we will communicate you by email. Is it okay?
Absolutely. Thank you so much. If you have more questions, just let me know, and I'm happy to answer and catch up directly with any experts who would like to know more. Thank you for having me. Have a great rest of the day, and thank you. Bye.
Have a great day too. Thank you. Что ж, благодарим вас за участие, за вовлеченность. Позвольте мне для заключительных замечаний данной сессии пригласить доктора Лизу Лим, профессора, ассистент профессора Высшей школы госполитики Назарбаев университета. Если вы помните, сегодня ранее Садвакас Нурхан Ушабаевич в своей речи сказал, что сегодняшняя конференция отчасти прошла благодаря ей, потому что это была отчасти ее инициатива. И для меня большая честь называть доктора Лим своим профессором, называть себя ее докторантом. So, Dr. Lim, Professor, the floor is yours.
Good afternoon, everyone. I'm sure you're very busy, and I'm sure you're very, very tired. I had an opportunity to speak, but somehow it got really delayed. So I'm just going to make my point in 2 minutes. So I'm just going to share my slide, and I'm going to make my points in 2 minutes. So thank you so much for your attention. Can you go to the slide that I asked you to? This one. Okay. So I just wanted to focus on, so I teach policy communication at public policy school. Communication is essential to public policy in democracy. And policy is just not made. It needs to be communicated to the public. I just wanted to talk about importance of effective, this case is going to be health policy communications. The first important is that we need to make sure that we need to communicate our policy so that public understand and compliance to it. So understanding meaning that what is the role, what is the policy indicate, what is the role, rule and a law of this, and then make sure if I fail this policy, if I don't follow this one, what is my consequences? So public needs to make sure that they need to understand. And then second, well, it's not particular in this order, but also remember we live in a very, what do you call, information disorder of society. We have a information, we have misinformation, we have disinformation. You know the difference. Malinformation is well, let me start with disinformation. Disinformation is some information disseminated to deceive somebody, deceive the public. Misinformation is it's unintentional, but it's really, well, it's not really intended to mislead people, but it's unintentionally. So it doesn't really harm anybody. But the malinformation is to disseminate, to harm the society, harm the particular community. So we need to make sure to have effective communication so that we reduce this kind of miscommunication and as well as its interpretations. The next one is that we also have empowering information decision-making, meaning that we need to make sure, consider multiple perspectives, analyzing relevant data and taking necessary actions and to evaluate various aspects so that we can make a wide decision. Because once policy is made, it's very, very difficult to change. Right? So we're not only looking at very short term, but we also have to look at it in a very long-term basis. So this is very, very important aspect of it. And many speakers talks about today about building a trust and confidence. And that's really a big issue for especially particularly in this country, that every speaker is talk about that they don't trust office, they don't trust, information from Ministry of Health. So it's really, really important that we build this trust issue. So we need to make sure that we provide effective communication so that we build the confidence with the community, with the public. So this is very, very important. And then lastly, we need to make sure that we have effectively engage with the public, meaning that long time ago, I don't know if it's still prevalent in this society. We have this very, very close model, meaning that top make a decision and just disseminate it. Well, it's not really that way too, because each community have their very different needs and particular things that they want. So we really, the community, before we actually making a communication strategy, we need to make sure that we need to listen to the different community and receive their different perspective to reflect in a different type of community. So it's not really one size fits all. So it's very, very important. That's why we talk about effective communication through public engagement. So we need to make sure that we need to make sure citizen as a center of design. Make sure the citizen is indicator. Make sure citizen as a service for the public. So next slide, please. So I'm just going to give you one example of sort of not communicating very well about the particular policy. This is the Kazakhstan wanted to have sustainable energy solution by building a nuclear facility, as you're all aware of it. Now, because Kazakhstan is facing an energy deficit by 2029, and also Kazakhstan government have to meet this United Nations Sustainable Development, reducing pollutions, right? Carbon dioxide, right? Emissions. And then also they have to meet the needs of all this energy for the public. So it's very, very important. In other countries like Japan and South Korea, other countries that use a nuclear facility. So they wanted to make sure that they have that kind of very similar to tackle the energy deficit by 2029. So the government starting from 2019, the public wasn't not really strongly against it, if you can see from the chart. But by going 21, 22, 23, look at this, how many people are not supporting about this. It's just a lack of communication through public to the community. So if you go to the next slide. So people are not really aware about this. And I'm sure there's a lot of phobia happening in the Kazakhstan community with the nuclear incidents from particularly in this region and also in Ukraine. So people are not really comfortable about that. And government need to have effective communication to make sure that we have this kind of strategy to tackle it. So many of them actually complaining about says, well, you know what? It's not well informed to the public, and it's a danger of accident and radiation. So government need to make sure that they have a comfort level to agree with this one. Also, the public talk about there's a lack of technician in terms of how to control the nuclear facility. And what about the ecological issue? What about this corruption issue? So they have so many issues to be able to agree with a government policy that needs to be solved through community engagements, right? To have a public support. So government is really caught in the middle, and they are very unprepared of this outrage of the community. So, Prime Minister sometimes, acknowledge it, and then they wanted to issue referendum. So this is where we are. So can you go to the next slide? So I'm going to end. I have a lot more, but I'm going to end this one, as I promised, it's 2 minutes. So why it's so important to design policy or even communication in a citizen center, because we have to reflect a very diversity opinions. Diversity has implication on range of perspectives and ideas. Don't even ignore the community. They probably know what they really want. And also, it's fairness. We have to minimize all this issue. So in order to provide the fairness, we really need to listen. It has to be both ways. And also, knowledge gain. So by mean that I'm sure we have many experts in a government level, but also community knows the best what they really need from the community. So we really need to get the insightful information from the community with what they need. So we have to reflect that. So knowledge is vice versa. Government top level can disseminate the knowledge. Also, a citizen level, we can also share our knowledge with the local needs. And effectively, it's all good. So we have to build this confidence together. So as I mentioned about that, all this policy making, also communication making has to be through community engagement, so that we can have a public trust, we have a confidence, we have all these things, so we can effectively work together for good for the government and good for the citizen. All the policy is really for citizen itself, isn't it? So if we don't reflect what they really need and what they really want, policy is going to fail. So I think it's very, very important to focus on community engagement to have effective communication, even policy making. Thank you so much.
Спасибо, доктор Лим. Повторю, что доктор Лим специализируется в вопросах коммуникации, риск-коммуникации, кризис-коммуникации. Физически находится здесь, в Астане, работает в Назарбаев университете, и она очень-очень открыта для сотрудничества. Можете непосредственно обратиться к ней, либо через меня для преодоления трудностей перевода. На этом мы заканчиваем нашу сессию, и для заключительных слов я хотела передать слово Сухамбердиеву Канату Абдуалиевичу, координатору программы иммунизации ВОЗ в Казахстане. Канат Абдуалиевич.
Спасибо, дорогие коллеги. Мы уже заканчиваем. Финальный комментарий. Прежде чем сказать финальный комментарий, так, 3 вопроса. Просто ко мне подходят, прошу моих коллег помочь. Где можно скачать презентации, спрашивают. Так, мы, наверное, будем создавать либо Google Drive, чтобы мои коллеги сейчас меня могли объяснить тогда участникам, где они могут скачать презентации. Хорошо, либо чуть позже, может быть, вы напишите здесь email Савле, вот здесь, чтобы все записали, и тогда вы уже напишите, чтобы вам презентации мы направили. Сейчас позже мы напишем здесь email, контакты. Теперь второй вопрос, сертификаты. Сертификаты, где регистрация? Там вы получите сертификаты, как участие, сертификаты WHO. Фамилии написаны не будут, вы сами напишите. Но печать, подпись стоит, ну, чтобы ошибок не было, поэтому. И по поводу постеров. Вы получили постеры по коре. Есть еще электронные версии постеров про коре. Мы тоже вам можем отправить, и вы уже можете потом самостоятельно в своей типографии распечатать. Постеры, согласованные с комитетом. Вот. Итак, финальный комментарий. Уважаемые партнеры, коллеги, друзья, спасибо всем вам за то, что остались с нами. Коммуникация – это очень важная тема. Почему это важно? Вот представьте себе, что вы пассажир в самолете. Как вы себя чувствуете? Некоторое беспокойство, да, непонимание того, что происходит. А если турбулентность, страх, боязнь. И когда сейчас поменялось поведение, командир корабля нас предупреждает, да, что сейчас будет турбулентность, и мы готовы, и нам легче. После слов командира. Вот раньше такого не было, помните? Вот так же себя чувствует население, которое приходит на вакцинацию, которое приходит в поликлинику, которое приходит в больницу. Они не понимают, что происходит, тем более большие длинные коридоры, куда идти. Сейчас мы начали меняться, поэтому эта коммуникация, это очень важно. Купить вакцину, это легче всего. Сейчас пока сверните, а то почему-то все внимание теперь на это. Опять коммуникация, да? Я же просил позже поставить. Значит, не так объяснил. Надо было убедиться. Поняли меня или нет? Так вот, купить вакцину – это легче всего, коллеги. Это легче всего. А вот провести вакцинацию без подготовки очень сложно. Очень сложно. А вакцинация – это не только закуп. Хотя и закуп сложно. Это же надо сделать прогнозы. Это надо планировать. Это надо бюджет выделить. Вакцинация – это обеспечение холодовой цепи. Это обученные сотрудники на передовой, кто работает по МСП. Это и регистрация НППИ. Это утилизация медицинских отходов. Это и достоверная отчетность. Очень важная достоверная отчетность. Потому что на протяжении 20 лет мы отчитываемся в ВОЗ, что вакцинация 98%. Почему вспышки? Вопрос. И, конечно же, вакцинация – это коммуникация между медработниками, прежде всего. Между медработниками и педагогами. И самое важное, между медработниками и населением. Вот коммуникация. Вот был вопрос, а мы готовы к пандемиям? А пандемии будут. Климат меняется же, появляются новые вирусы. Это неизбежно. Вот чтобы ответить на этот вопрос, готовы ли мы к пандемиям, задайте себе такой вопрос. Вот если бы я вернулся в 2020 год, 2021 год, что бы я сделал по-другому? Вот этот вопрос просто задайте себе. Что бы я сделал по-другому? И тогда мы можем дать себе ответ, мы готовы к пандемиям или не готовы? Меня, как представителя Всемирной организации здравоохранения в Казахстане, как вот участник конференции, радует, что второй день конференции сопровождается такая хорошая дискуссия. И в настоящее время это одно из самых важных совещаний в национальном календаре, имеется в виду конференции, ну и в календаре конференции глобального здравоохранения. То эти 2 дня во многих странах обсуждают эти вопросы. Именно ВПЧ, элиминацию рака шейки матки мы поддерживаем. И эта конференция объединяет людей из системы здравоохранения, включая вас, специалистов, эпидемиологов. Я вижу, что есть из ПМСП тоже, специалистов по коммуникациям, гражданское общество, научные круги и многих других. В этом году мы собрались вместе во время вспышки кори и краснухи. Вспышка является ужасным напоминанием о том, как быстро здоровье тысяч людей может быть поставлено под угрозу без коммуникации между различными сторонами. Сейчас также человечество сталкивается с другими огромными угрозами. Угрозами имеется в виду для здоровья. Это войны, климатический кризис, рост бедности, распространение голода, быстрое истощение природных ресурсов, стихийные бедствия, глобальные, вот у нас региональные вспышки болезней, в том числе вот вакциноуправляемые. Всего лишь 5 месяцев назад, в мае, ВОЗ объявил об окончании глобальной пандемии, глобальной чрезвычайной ситуации в области здравоохранения, которая была вызвана распространением COVID-19. Мы достигли этого рубежа благодаря высочайшему профессионализму и самоотверженности медицинских, медико-социальных работников, а также новаторским достижениям исследователей и разработчиков вакцин. Однако пандемия COVID-19 обнажила также вопиющее проявление неравенства в нашем мире, из-за которых беднейшие и самые уязвимые слои населения пострадали больше всего и смогли в последнюю очередь воспользоваться вакцинами и другими средствами борьбы с инфекцией. Мы наблюдали отсутствие коммуникации и координации между странами, между медицинскими организациями. Мы наблюдали политизацию научных вопросов, попытки подорвать доверие к нашим институтам при помощи дезинформации. Мы наблюдаем сейчас вспышки вакциноуправляемых заболеваний и слабые коммуникации сейчас наблюдаем между медработниками и населением. Одна из величайших трагедий пандемии COVID-19 заключается в том, что этого всего можно было избежать. И мы не можем допустить, чтобы горькие уроки пандемии ничему нас не научили. Именно поэтому ВОЗ считает важным построение сбалансированной, инклюзивной коммуникации для обеспечения мер борьбы и готовности к пандемиям, к вспышкам, а также при проведении вакцинации. Я настоятельно призываю вас всех уделять особое внимание укреплению коммуникативных мер, в том числе вовлечению сообществ на любой кризис. Вместе мы сильнее, и поэтому многостороннее сотрудничество имеет столь важное значение. Благодаря такому сотрудничеству разработаны планы как по вакцинации, так и планы по ВПЧ. Дорогие коллеги, друзья, в 1948 году мировое сообщество, испытав ужасы войны, объединило усилия для создания Всемирной организации здравоохранения, исходя из убеждения о том, что здоровье является не только одним из основных прав человека, но и фундаментом мира и безопасности. Их тогдашние убеждения должны разделять и мы сегодня. Через коммуникации и совместные усилия мы не только укрепляем, восстанавливаем и защищаем наше физическое и психическое здоровье, но и врачуем полный розни и страданий мир. Еще раз благодарю Министерство здравоохранения Республики Казахстан, Комитет санэпидконтроля, Европейский союз, Школу медицины Назарбаев университета за их деятельную роль и партнерскую поддержку. Я благодарю наших коллег из Республики Каракалпакстан, Республики Туркменистан, Республики Кыргызстан за то, что вы приехали, за вашу поддержку и опыт. И вчера мы слышали одно из ключевых сообщений, что Казахстан не то, что там провалил вакцинацию, что вы дали нам опыт. Вы нам дали опыт. И на вашем опыте мы сделали такую вакцинацию успешно. Но я хочу сказать, что кроме Казахстана, также была неудачная попытка, это и у Армении, у Японии. Поэтому Казахстан дал не только опыт, но он и дает надежду этим странам. Японии и Армении, например. Они на нас смотрят, как мы второй раз попробуем. Поэтому мы даем им надежду на внедрение вакцинации против ВПЧ. Благодарю всех вас, дорогие участники, за вашу твердую приверженность нашего информационного взаимодействия при возникновении таких событий, связанных с безопасностью для достижения цели по охране здоровья, как одного из прав человека. Это и самостоятельная цель, это и средство обеспечения развития. Сау болыңыз, денсаулық зор болсын, үлкен рахмет. До встречи. Теперь можно.